Okay. So, why are we studying about this gastrointestinal symptoms? It is because it is very common. No, it is very common. The GI symptoms are as common as pain. Okay, so the common GI symptoms we usually come across include oral thrush, starting with the mouth, the oral thrush, stomatitis, dry mouth, nausea, vomiting, constipation, diarrhea, and intestinal obstruction. So today in this class, we'll be learning about only nausea and vomiting. Okay, because it is very important and it is very common. And okay, let's learn about it. So see, nearly 40 to 70 percentage of the patients with advanced cancer has nausea and vomiting. See the number 40 to 70, is it a small number? No, it's a big number. So it is very important. Okay. And management involves accurate assessment. This is said because most of the time when we see patients, no, patients come to us with either nausea or vomiting. Most of the time we'll be prescribing only one drug. The common one which I used to prescribe was ondansetron or amycin. Whatever vomiting, we only know that. So we don't know about what are the mechanisms. We just know that the patient has come with vomiting and we give some tablets. So from today's class, that should change. Okay. There are different mechanisms, and for each mechanism, the treatment is also different. That's how it works. Okay, so today we are going to learn the different mechanism and targeted drug therapy. That is it. Various mechanism and their drug therapy rather than prescribing the same antiemetic for all types of vomiting. Okay, so how will it affect? How is this nausea? How does this nausea and vomiting affect? So, just I'll give an example. Think about somebody else in your family, someone else in the family having nausea for few hours. And it will be difficult for us to see them just for few hours like that. Just think about our patients who might have this kind of nausea for hours, sometimes days, sometimes weeks. Okay, that is very distressing. Okay, so that will affect their daily functioning. Can they eat something? Can they sleep? Can they drink some water? Nothing. So that will affect the daily function of the water, daily function, and affect that will result in a poor quality of life. The second thing is there is no compliance to cancer treatment. You know why? Sometimes this patients who takes chemotherapy, no, they will have after taking the chemotherapy, they'll start having vomiting, right? So what they will think, they'll think that see, this is very distressing. Chemotherapy, it will give me vomiting. I'm going to stop it. Okay, I'm going to stop taking it. So what they'll do, they'll stop the chemotherapy, like the treatment. Okay, and is it good? No. So we have to find something to reduce the nausea and vomiting. They are not able to eat anything or they are not able to drink anything. That's why they are stopping the treatment. That is very distressing. Now there is no compliance to analgesics. See, if a patient is having severe pain, okay, the patient is having severe pain and the patient is on analgesics, but the patient is having nausea or vomiting. Will they be able to take the tablets? No, that will cause a hindrance. The patient will stop taking tablets for analgesics, right? So what they'll do, they will stop taking the analgesics and pain will persist. That will be causing so much distress to the patient. And poor fluid and oral intake. Family will also be in distress. So this is the effect, or this is the effect of nausea or vomiting in the daily life of patients. So what are we going to do? We are going to stop or reduce the symptoms. Okay, sometimes we won't be able to stop the symptom like all of a sudden, but what we can do, we can reduce the frequency. At least if he was vomiting 10 times before, now it we can reduce it to 1 or 2 times. That will be somewhat adjustable for them. Now, to establish compliance to the treatment by reducing the frequency or by reducing the number of times, we can establish compliance to the chemotherapy treatment. To enable analgesic medication, they can take the medication and thereby to improve the quality of life. Okay. So that is the importance of, we were talking about the importance of nausea vomiting, why we want to study it, what is the use, how will it affect, and what are our plans or what is our goal. Okay. So now let us study about different words and their meaning. Okay, we'll be knowing nausea, vomiting, everything is everything the same? No, everything is different. Okay, so let's study what is emesis. Okay, emesis means it is a biological defense mechanism. Vomiting, what is vomiting? Is it that is inbuilt in our body? Okay, that is when like a chameleon. I have shown a picture of a chameleon. Chameleon changes its color, right? It changes the color to protect itself from the enemy. Like that, our body has also what they have maintained the defense mechanism. When some toxic material or some harmful substance enter the body, the emesis will happen and they will vomit it out. Okay, but what happens when it is too much? That becomes a big problem for us. So there are phases of vomiting. This nausea, retching, vomiting, and regurgitation. Everything is different. Okay. Nausea means it is only an unpleasant sensation. Okay. Just the sensation that may or may not lead to vomiting. The patient might be having only that sensation. They'll be telling, I don't have vomiting, but I have that sensation that something is in the behind the throat or something like that. Now, retching. Second one is retching. Retching means the spasmodic contractions. They'll have abdominal pain, but that also may or may not result in vomiting. The patient will have that feeling, but nothing will come out. So that is retching. Okay, nausea, retching. Now vomiting. What is vomiting? Vomiting means there is a forceful expulsion of the gastric contents. Okay. Now the fourth one is regurgitation. Regurgitation, we see that in small children and all, when they take milk, the milk will come out, right? So as curd or something like that. So that is regurgitation. So you should be knowing what the patient is telling. Okay. Is it nausea or is it retching or is it proper vomiting or is it regurgitation? For that, when the patient tells you, you should know this. You should know the difference about all these things. Okay. Now, nausea. What is proper nausea? Nausea means it is an unpleasant sensation in the back of the throat or in the stomach. Okay. That proceeds the vomiting, but may or may not result in vomiting always. We already discussed. One second. Please hold 1 second. Sorry for the interruption. Can you see? No? You can see, right? You can see the slide, right?
Ma'am.
Is it audible?
Yes, ma'am.
Okay. Sorry for the interruption. Okay. So, when the patient is having nausea, that is an unpleasant sensation. So, the thing you have to do is clarify whether the patient is reporting nausea, vomiting, retching, or regurgitation. You have to clarify. Okay. Now, there are four types of vomiting. Can you hear me? I have power interruption here. I'm so sorry.
Yes, ma'am. You
Oh,
can
I'm so
continue.
sorry. I'm so sorry. There is some
It's
power
fine. It's fine.
interruption here. Okay. Okay. So there are four types of vomiting. What is acute vomiting? Acute means it occurs within a few minutes to hours and resolving in 24 hours. That is sometimes a patient after taking chemotherapy, they'll start having vomiting as soon as they take the medications. Okay, that is the acute one. Now, delayed is a type which we see very commonly. Those patients with cancer patients, after taking chemotherapy, they won't develop the problem like within few hours. Most of the time, it will be after some hours or sometimes after 2 to 3 days. The patient will take the chemotherapy on Thursday, and they'll start having vomiting like after Saturday or Friday evening, like that. So that is the second type. That is a delayed. Now, what is a breakthrough? Breakthrough means you give medications. The patient is having vomiting, you have given medications, and in spite of that, sometimes the patient will have 1 or 2 episodes. That is known as breakthrough, once in a while. That is okay. Now, the fourth one, the refractory. Refractory means unmanageable. Whatever you give, the patient will be having vomiting, and whatever tablets you give, nothing is going to work. So that is called as refractory vomiting. And now the last one, anticipatory. This is something tricky. Okay, anticipatory. This is not very common, but at least in your life, somebody will have come and like after taking chemotherapy, some patients will be having this. So what is this anticipatory vomiting? That is a conditioned response prior to chemotherapy. I'll give you an example. One patient, okay, he's having chemotherapy on Thursday, but his relatives have come and told you that, sister, see, the patient, he's having only chemo on Thursday, but he is vomiting since Tuesday, like last Tuesday. Well, how is that possible? Is he acting? Is he telling lies? Does he really have vomiting? Yes. Actually, the patient is having anticipatory vomiting. That means the thought of taking chemo, no, the patients will have vomiting. That is anticipated. That is because of our brain. Okay, that is because of the cerebral cortex. We'll learn about it later. So, in short, these are the different types. Okay. First, you have to clarify. I think it is clear. Nausea, vomiting, retching, and regurgitation. Four things. All the four are different, and then you can mention the vomiting like this. If it is acute, or if it is delayed, or if it is a breakthrough vomiting, you can write it. When you document this, all these words are very important. The patient came with refractory, or the patient came with acute vomiting, or the patient came with refractory vomiting. Everything was tried on him, but he did not improve, or anticipatory vomiting. So the different causes of vomiting. So this is a small slide, and these are the different causes. Chemically induced nausea, that means when you take drugs, the most common drug causing nausea and vomiting is antibiotic. Okay, so you have already learned about opioid, right? Opioid, the most common side effect of opioid is nausea and vomiting. So all these things, all these are chemical, these all these things comes under chemically induced nausea. Opioids, antibiotics, cytotoxic drugs, then toxic like food poisoning, all these things are chemically induced. Cytotoxic drugs means chemotherapy drugs. Okay, now the second thing, gastric stasis, like anticholinergic drugs, opioids, ascites, gastritis, all these things will cause gastric stasis. The peristalsis will not happen. So the food stays in the stomach and it will come out. The patient will have fullness. Now, stretch or distortion of the GI tract, like constipation. We'll study in the next class, we'll be studying about constipation. So, there, because of the stretch, okay, the stretch or the distortion of GI tract due to constipation, the patient will have nausea vomiting. Serosal irritation, like liver metastasis, all these things can cause nausea and vomiting. That is why it is very common. Okay. Now, the next one, raised intracranial pressure. That is also tricky one. Okay, when there is some tumor or when there is some cerebral edema, people might have come to your OP, or when you are in a casualty, you might have seen people with raised intracranial pressure, like patient having cerebral edema. SOL means space occupying lesions. That means tumors. Okay, IC bleeds, all these things. Then fourth one, the treatment. I was talking about this because the treatment is little bit different here. We learn later. Okay, just keep this in your mind. Raised ICP, and that treatment is different. Then movement associated vestibular disorder, that is motion sickness. Patient will have when they travel and all, they'll have motion sickness, right? That is also different. And the last one is anxiety induced, that is anticipatory vomiting. I think somebody has unmuted. Or was it a doubt? Should I pause? No, right? Can I continue?
Yes, ma'am.
Okay. So these are the causes. These are the different causes of vomiting. Now, coming to our treatment, what are we going to do? How are we? Now we studied, we classified it, we understood what actually it is, and then we understood what are the different causes of the vomiting. Now we are going to talk about the principles. That is, how are we going to manage this patient? That is a very important one. Okay, so One patient came. He told that he's having vomiting, and are you going to suddenly jump into writing medicines for them? From now onwards, it should not be done. Okay. There are some non-pharmacological measures. Non-pharmacological measures means without giving medicines, you can try some other methods that will ease the patient. Okay. That will also be helpful. Sometimes the patient might be having only mild vomiting, 1 or 2 episode or some mild nausea vomiting, and suddenly you're jumping and you're throwing so much of medications in it. Is it required? No need. So first we have to learn about the non-pharmacological methods. What can we advise them? As a nurse, as a doctor, what are the non-pharmacological measures that will help them a lot? Because sometimes these patients will be like they'll be fed up with taking a lot of medications. Already they'll be having some 8 or 10 medicines, and when you give some or 2 or 3 medicines for nausea and vomiting, that will be burden for them. Okay, so if it is mild or something like that, you can first try the non-pharmacological measures. If there is some exam and all, they'll ask this. Okay, this non-pharmacological measures. So what are the non-pharmacological measures? This is very easy. Avoid foods which precipitate nausea and vomiting. See, I'll tell you an example. If the patient is telling like, see, I don't like apple. I get nausea when I take apples. But you are a medical professional and you are telling apple is very good. You have to eat it and you can't skip that. You should eat it. Is it required? No. If the patient tells that that is precipitating his nausea, then avoid it for some time. So after some time he'll be okay. Sometimes he'll be taking happily he'll be taking apple. I just told an example. So avoid foods. That is what. Don't force feed. Okay. Sometimes they'll be telling, I don't want rice. I don't want this. Avoid it. Okay. Sometimes even the that smell of the rice or smell of what lemon or something like that, they won't be liking it. That's all. That's not because of their problem. It is because of their cortex, cerebral cortex. It is that is keeping a memory that it is not like you will have some nausea. Don't take it. So that is why they are avoiding it. So you have to don't just force feed them uh, teach the caregivers also about this. Out of love they'll be telling that this is good for your health, you can't avoid it, you have to take it. But you should be telling them, you should be able to tell them. You will tell this only if you know this. Okay, that's why I'm stressing on this. Don't force feed. If the patient is telling, I don't want it, that is causing some problems for me, I am not liking it, then don't force feed. Okay. Then calm and reassuring environment away from the sight and smell of the food. Okay. Calm and reassuring. Open the curtains, open the all these things. Fresh air, give some fresh air. Nurse in upright position. Nurse means feed. Feed means make the patient sit. Okay, make the patient sit and feed. Ask the caregivers to sit and feed. It is always good to feed the patient when the patient is in upright position. Then control of malodor. That I'll give you an example. One patient came. Okay, he's having nausea and he's telling that see, he's having a colostomy bag or some tumor is there here near his chin or cheek area, and he's telling that see, whenever I eat, the smell is causing me a big problem, and I can't eat because of the smell. But I'm having nausea and vomiting. Okay, I'm vomiting because of this, and you are writing some antiemetics, some drugs. Will it help? No, it will not help. So what you can do, you can control the malodor. Okay, you have to reduce the smell. There are so many methods you'll be learning about how to take care of a fungating tumor or a colostomy and all. You will learn about it. So you have to keep this in mind. If the patient is having this thing or something, some oral malignancy and all, the smell is so bad. Okay, it will be difficult for them to. They'll be also knowing that smell, right? So all these things are very important. These are the non-pharmacological measures. Avoid food which precipitate, calm, reassuring environment. You have to give some fresh air, open the doors, open the windows, put on the fan, everything. Okay. Give them fresh air, take them out, make them sit on the veranda. Okay, like that. And now the dietary modifications, give them small frequent meals. Don't ask them to take so much of rice together. They won't be able to take it. Like, firstly, they won't be able to take like a very big quantity. Ask them to split the meals. Okay, take at something lightly at 8 o'clock. Then some after some time at 10 o'clock, whatever you can take. Take whatever you can take. Then after 12, like give small breaks, small meals. Okay. And they avoid fatty, sweet, spicy, all these junk foods and all. Okay, avoid it. Carbonated drinks like Coca-Cola, like all those things and all. Now, no force feeding that I already told. Okay, don't forget that. So these are the non-pharmacological measures. Now coming to the pharmacological measures. You have to listen very carefully to this. Okay, then only you'll understand. This is very simple. This is very, I'll repeat it so many times so that it gets onto your head. So about the pharmacological measures. What drugs? Now we are going to learn about the mechanism and their treatment. Okay. So what is causing vomiting? What is the thing which is causing vomiting? We have a vomiting center. Okay, in the medulla of our brain, we have a vomiting center. So whenever this vomiting center is activated, we vomit. Okay, so now we have to learn what are the things which activate this vomiting center. And that is how we are going to give medications for that. So see, stimuli. What are the stimuli for the activation of the vomiting center? So first one is the peripheral area. So this vomiting center is in the brain, right? So the stimulus is if it is coming far away from peripheral area. Peripheral area means gastric mucosa or other parts of GIT. So one stimuli is coming from, keep this in mind, okay. Peripheral area means gastric mucosa. Second one, sensory stimuli, that is from cerebral cortex or vestibular apparatus. And CTZ. So these are the three stimuli. What is CTZ? CTZ means chemoreceptor trigger zone. Okay. So the next picture. So this is what I told. Okay. We have a vomiting center and this vomiting center is stimulated from different places. Okay. When it is from the GIT, when you take some chemotherapy drugs or when you take something orally, antibiotics, something like that, that will go to the GIT. And from the GIT, it will stimulate the vomiting center. Second one, from the cortex. I've shown the picture of a brain. In the front of the brain, we have a cortex. From the cortex, they give some stimuli to the vomiting center and the vomiting center is activated. CTZ. CTZ means chemoreceptor trigger zone. In that area, no, there are a lot of receptors. See, I have named few. D2 means dopamine receptor. 5-HT3 means serotonin receptor. Opioid receptor. Opioid acts on the mu receptor. Okay, sorry. Neurokinin. H1 means histamine receptor. So the CTZ is a collection of so many receptor. So whenever some in our body some neurotransmitters like serotonin or dopamine something is released, that will come and act on this CTZ and that will cause the stimulate the vomiting center and we vomit. And the fourth one, last one, vestibular system. When we travel, when we have some motion sickness, some the vestibular inside the ear or ear is causing the balance, right? Ear is controlling the balance, so it will release the acetylcholine and histamine. That will in turn causes stimulate the vomiting center. So we'll learn in detail one by one. Okay. So how does this patients having chemotherapy and radiation have nausea and vomiting? Simple. We have already discussed. When you take some chemo drugs, it will go and act on the stomach or in the GIT mucosa. In the picture, first one. Okay, GI mucosa. Same here. So what will cause? In the gastric mucosa, they will release some serotonin. You know what the serotonin do? Serotonin will go and act on the receptor of the chemoreceptor trigger zone and it will cause vomiting. So that is why patients having chemotherapy and radiation have vomiting. Simple. Understood? Is it clear? When you take something orally, some chemo drugs orally, it will go and act on the gastric mucosa. It will release serotonin. That will go to our CTZ, right? CTZ is the main center. And that will in turn stimulate the vomiting center. Now, so we learned about it. Okay. So what can we give for this treatment? we have to block the serotonin. Serotonin is causing the problem, right? So we have to block the serotonin. So what is the treatment? Treatment is cetron. For chemo-induced vomiting, the problem is because of serotonin. So we give cetrons. Example of cetron is ondansetron. So you will have some questions like this. What is the drug of choice for chemo-induced vomiting? Answer is ondansetron. Cetron. Simple. Okay? Don't forget it. So that is why for chemo-induced vomiting, we give Emiset or something ondansetron for nearly 3 days and all. 3 or 5 days we'll give. Now, the second thing, most of you must have worked in an ICU or post-op after surgery. You have seen, no? After surgery, the patients will be having nausea or vomiting, right? Why? Because during the time of the surgery, the anesthetist will be giving some opioids to control the pain, right? So what will opioids do? We already know morphine, all these things are opioids, right? You have studied in the previous class about pain. Opioids will have nausea and vomiting. So how does this opioid act? This opioid act, this stimulates the D2 receptor. Opioids will stimulate the D2 receptor in the D2 means dopamine, CT set, in the CT set, and also the mu receptors in the CT set. Since opioid is causing too much problem, they are activating so many receptors like D2 receptor, mu receptor in the CT set, and it will cause vomiting. So what we'll do? So we'll give a dopamine antagonist for chemo-induced vomiting. Who was causing the problem? Histamine, serotonin was causing the problem, right? So we give a cetron, ondansetron, emiset. Here, post-op vomiting because of the opioids. We already learned in like opioids, right? When you prescribe morphine, you always have to give a prokinetic, antiemetic along with morphine. You have to give an antiemetic and also you have to give some bisacodyl, something like that. Okay, to prevent constipation. So this is a dopamine antagonist. What we give is metoclopramide or domperidone. We usually prefer to give metoclopramide here. Okay, so that is the cause behind post-operative nausea and vomiting. Now, vestibular apparatus, motion sickness. For motion sickness, what will is it ondansetron? Will it help? No. Why? Because when the patient is travel, no, not the patient. When if we also travel to some hilly areas of some hill station, we'll have some motion sickness, right? So histamine is a problem there, and what we give antihistamines. That is a treatment. Now coming to a cerebral cortex. Look, cerebral cortex, the taste, smell, sight, and memory of the food. The memory, the cerebral cortex is always involved in the memory and all. So what will it cause? The cerebral cortex will stimulate the vomiting center and that will cause anticipatory vomiting. And the treatment part we'll discuss. So we have already learned about this. Next time when someone comes and tell you that they have, when they think about food or when they have the taste or smell, all these things are causing me vomiting, and will you write the usual tablets? No, you have to keep that, you have to know that it is different. Okay, this is called as anticipatory vomiting, or it's known as anxiety induced. Okay, now revision: chemotherapy, anesthetics, opioids, all these things acts on the CT set. What I said earlier, same thing. Okay. So what are the receptors in the chemoreceptor trigger zone? So many receptors. Just learn one or two. Dopamine, serotonin, opioid, histamine, all these things are present in the CT set. And this will cause vomiting. And see, sight, smell, taste. What will be activated? Cortex. When there is a fear or anticipation, the thought about taking a chemotherapy, that fear, that is an anticipation, anxiety. That will stimulate the vomiting center. And what will you give for anticipatory vomiting? What is the treatment? We give benzodiazepines. Okay. What we give? What are the examples of benzodiazepines? Alprazolam, Hmm? Benzodiazepine, all these, diazepam, all these are examples. Okay. So this is the treatment for anticipatory vomiting. Okay, Alprax, what we write usually, right? Midazolam. Okay. All these things we give for anticipatory vomiting. So just go through the slide that the receptors and drugs. Example, when acetylcholine is causing the problem, we give hyoscine or dicyclomine. What are the examples of antihistamines? Promethazine. We already told no promethazine for motion sickness and all. Promethazine, diphenhydramine. All these are examples. D2 antagonist, dopamine antagonist. What are the examples? Metoclopramide, domperidone. Serotonin. What is example? Cetrons. Okay. Neuroleptics and substance pain, all that is not required for you. So once again, the revision. See, look, the vomiting center is activated by higher cortical center. What we give there? Benzodiazepine. Upside, look up. The first one, higher cortical center, memory fear, benzodiazepine is given. Second one, chemoreceptor trigger zone is activated by chemotherapy, anesthetics, opioids. It will stimulate the vomiting center and cause vomiting. Now, third one, stomach or small intestine, like chemotherapy, drugs or surgery, all these things, the serotonin will be released. It acts on the vomiting center. Now, fourth one, labyrinth. Labyrinth means inside the ear. Okay, histamine and vomiting is caused. I'm repeating this so many times because it is little tricky, but it is very easy. I hope you all are understanding. Stop me if you have any doubts. Okay. I'm just continuing because I'm repeating it many times. I think I'm thinking that you are understanding this. Okay. You can stop me if you have doubts. Now, same thing again. So, what are the stimuli for chemoreceptor trigger zone? Already told opioids, chemotherapy drugs. See, now something else is coming biochemical, calcium, renal failure, liver failure. See, we have talked about the post-operative unit. Now, think about the ICU. In some patients, you might have seen the patient will be very delirious, or sometimes the patient will be showing so much of nausea and vomiting, and that patients might be having renal failure. All organ failure patient, liver failure, renal failure, they might be also having due to excessive amount of urea. All these things the patient will be having nausea, vomiting. That is because this urea, all these things will act on the chemoreceptor trigger zone. For that, treatment is different. That will also be discussing. Vestibular system, we already told inside the ear, opioids, a tumor, all these things can stimulate. Cortical, anxiety, ICP, raised intracranial pressure can stimulate the cortical center. Now from peripheral. Peripheral means we already told when we take drugs like chemotherapy, radiotherapy, GI irritation. Okay. So now, so when you give some drugs to a patient, it should be as per patient's condition. If some patient is able to take the tablets orally, give them orally. Why you want to give injection when the patient is able to take everything orally? No need. Okay. So if the patient is able to take food orally, give it a tablet, give it as tablets. It will be easy for them. But in reverse, if the patient is not able to take anything by mouth, okay, if the patient is having severe vomiting and nausea, then you have to give it by IV or IM or continuous subcutaneous infusion. Or sometimes some drugs are available as suppository, some is available as sublingual, like below the tongue. Transdermal patches. It is little expensive, but that is also there. Okay, these are the different modes. How can you give the medicines? So keep this in mind. If the patient is able to take the drugs orally, if he's fine, give him as oral. There is nothing like when the patient comes with vomiting, you have to give it by IV. Nothing like that. But if the patient is having severe vomiting, he's not even able to drink like a sip of water, then you can give IV. That is not a indication. Okay. Hope you understood. So, the thing, treatment should be mechanism based. We already told, no? So many mechanisms are there. If it is ear, if it is like brain, the treatment is different. And the basic thing, this should be a catch point of this class. Mechanism, the treatment, when you prescribe an antiemetic, it should be a mechanism based and not generalized. So now tell me some drugs causing nausea, vomiting, the drug which you have already studied for pain. Can someone tell me? Can someone tell me some drugs causing nausea, vomiting? The one you have studied for pain. Nobody's answering. The drug which you gave for pain, which is the drug you have given for severe pain? Can someone respond? If it is wrong, also that's okay.
Ma'am, the morphine,
Yeah,
diclofenac,
yeah. Okay,
they
that is
already
it.
put it in chat box.
Yeah. I just asked. Okay, we are going to talk about morphine. That's why I asked. So, morphine is very important. Okay, how does it act? Morphine acts by different. It is not only one mechanism. Morphine by different mechanism. It is causing nausea and vomiting. So, morphine acts by direct activation of CT cell. Okay, morphine particularly means opioids. It causes gastric irritation and it causes gastric stasis also. Okay, so just now, we already told the biochemical causes, the patients who are in ICU and who is having uremia, hepatic failure, ketoacidosis, hypercalcemia, all these toxins and all, no? Well, these patients, what is the mechanism of action? That will also directly stimulate the chemoreceptor trigger zone. Okay, now raised ICP. See, when you have a tumor in the brain, or when there is some tumor, the pressure inside the brain increases, right? The brain is kept inside the skull and it is very tight and it's a small compartment. So even if a small growth happens, when it becomes big, no, it is space occupying. It is occupying some space and the tension inside the brain increases. So what can we do? Sometimes some tumors, nothing can be done. It's like some incurable. The doctor has already told it has spread everywhere, so much of metastasis, and we won't be able to do anything. And the patient is having brain mets. Okay, brain metastasis to the brain. What will you do? Nothing can be done. So what here we'll do is we give steroids. Steroids is a wonderful drugs. Okay, for raised ICP. Patients having brain malignancy could be primary, secondary brain tumor. We give a steroid. Well, the most commonly one is dexamethasone. How this works? There will be some kind of edema. For every tumor, there will be some kind of edema around the tumor. We can't reduce the size of the tumor, right? It is very big. What we can do, we can reduce the edema around the tumor. What we can use? We can use steroids. Okay. So when there is a growth inside the brain, the ICP, inside the brain, the pressure will increase. You know what happens when the pressure increases? The patient will have nausea and vomiting. In that case, if you give ondansetron, will it work? If you give antiemetic, will it work? Nothing will work. It will work only if we reduce the tension inside the brain. We can't, sometimes we won't be able to have a cure for this tumor. So what we'll do? We will give steroids. Steroids are anti-inflammatory in nature. That means that will reduce the edema. Okay. So today you have to, this should be in your mind. Okay, for raised type patients with brain tumor having nausea and vomiting, you can give steroids. You can give steroids, dexamethasone. Sometimes we give 16 milligrams. Sometimes we give 8 milligram. We have to give it for a few days and slowly taper it down. Okay. Or you can also give radiotherapy in some cases. If it is allowed, radiotherapy. You will not be able to prescribe it, but these are the treatment options for raised ICP. So you have to keep this in mind. So I think two new things you have learned today might be anticipatory vomiting and raised ICP. I think so. Okay, so don't forget about this. The treatment of raised ICP and anticipatory vomiting is not antiemetics. Okay. For anticipatory vomiting, it is benzodiazepines. For raised ICP, it is steroids. Okay, hope it is clear. So when you give medications, anticipate the need while starting morphine. Like we already know these opioids will cause nausea vomiting. Will we wait for the patient to develop this one? Let's not say, oh, we'll give medications. I'll give morphine and I'll prescribe antiemetics if he's having it. Don't do that. Where if the patient is getting all these things, that will be a big problem for him. So we already know, right? We already know that if we give morphine, the patient will have this kinds of problems. So that is known as anticipation, thinking before. So that is why when you give morphine, you give antiemetics. Okay. and laxatives. Bisacodyl is a laxatives. Don't forget. Okay, that is a key point. Use adequate and regular dose. This is also very important. Someone comes and asks you, someone comes and tell you that I'm having vomiting in this problem. You will give one tablet. I take this one tablet and it will be fine. One tablet is enough. If when the nausea subsides, don't discontinue it. Don't do like that. Use adequate and regular dose. All these medications will work only for at some to up to some hours or some like few hours. So you have to regularize it. I think it's already discussed in that pain chapter. Regular dose is required. Adequate, not suboptimal. Take if you're telling like take half tablet and take it. You might be telling because of the fear, but that will not be enough for the patient. So give adequate dose. If it is one tablet, prescribe one tablet. One tablet in regular dosage. Metoclopramide, like Perino, the usual common brand name is Perino hours. So if you are asking the patient to take one tablet, what will happen after 6 hours? The patient will start having vomiting again. So what you have to do? You have to regularize. Okay, regularize the tablet. Now, tablet, not like the generalized one. Combinations if necessary. See, it is not like giving only one medications. You have to, when you start, you can start with one medications. You tried with one medications, you have regularized it, you have given a adequate dose, but still it is not controlled because some other mechanism causing nausea vomiting. You can give combination if necessary. It is not like you have to give only combinations. Okay, you can start with one, and if it is not working, if it is not like you feel like something also is causing nausea, you can give it. Anticipate alternative routes also. Now, we already told dopamine antagonist, antihistamines, anticholinergics. These are the different drugs. So, a few points about each drugs. Metoclopramide. Okay, few things you have to know. Okay, metoclopramide, how does it act? It acts by so many mechanisms. It is a D2 antagonist. It has 5-HT3 antagonist. It is having a cholinomimetic action. That is, it's a prokinetic. We know, no, opioid. What will opioids cause? Opioids will cause gastric stasis. It will slow down the peristalsis. So what will this metoclopramide do? Metoclopramide as a prokinetic, it will stimulate the gastric mucosa and the gastric peristalsis will occur. So that is the importance of metoclopramide. Okay, you can give those from 30 to 120 milligram, and usually we start with 10 milligram TDS. Okay, when you prescribe morphine, you have to start metoclopramide along with morphine. Okay, when the patient is taking first time morphine for the first time, you have to give metoclopramide that time itself. Start with 10 mg TDS. See, I've already told the duration of action of metoclopramide is 6 to 8 hours. So when if you give one tablet, it will not work. That is why you give it as like 4 times a day, 6 hours. No, duration is 6 hours. So you can give 6th hourly. That means 4 times a day. Or you can give 8th hourly. That is TDS. Now, few things about haloperidol. Haloperidol, it's a D2 blocker. We already told, no? For it is when the CT cell is stimulated, haloperidol acts on directly on the CT cell. Okay, so it is also used as an antipsychotic. You know Serenase, right? This is so Serenase can be used. Haloperidol can be used for nausea and vomiting also. It is not only antipsychotic; it has this antiemetic property. So it is given for morphine induced. If the patient is a continuous vomiting due to after taking morphine, you can give haloperidol because morphine is directly acting on CT cell. Haloperidol is an antiemetic which acts on CT cell. So like that it is used. You can give single dose haloperidol 1.5 milligram per day. Just keep this in mind. So it directly acts on CT cells. So already told in uremia, in hepatic failure, acidosis, all these things, ICU patients, sometimes they'll be having all these kinds of problem. And that is because, you know why? All this urea and all will directly act on the CT cell and causes a vomiting. So you can give haloperidol for that. Understood? Now, you have given all medications. Now you have to document the likely causes. Sometimes whatever we give, it will not work. We are not God. Like it is very difficult for us to find what is the real cause. So if you're suspecting something, you have to write it down, document it properly. Yeah, we are suspecting intestinal obstruction, or this is due to urea, or is it due to raised ICP? All these things you have to document it properly. Okay. And also rule out other cause. Sometimes severe pain. Severe pain itself can cause nausea vomiting. Think about yourself, you're having a toothache, severe toothache. Okay. Toothache means severe toothache, and somebody is giving you some food. Will you be able to eat the food? Will you able to have the food? No. So that itself can be a cause. So rule out all these causes. Sometimes infection, sometimes due to cough, continuous coughing, the patient, the because of the vagal reflex, patient will vomiting. Patient will vomit, and you are giving tablet ondansetron. Will it work? No, that will not work. Anxiety, constipation. The patient is having constipation for a very long time. And we already told in the causes of nausea, vomiting, that due to gastric distortion, due to constipation, the stool, the fecal matter will be there, and that will cause distension, and the patient will not be able to eat. So you have to rule out all these things. Then only you have to start antiemetics. Now, always prescribe. Again, we are telling the most appropriate based on the receptor, not like generalized. Right stat doses. When patient comes with vomiting and you are sending them back, and you go home and take this. Not like that. You have to give one tablet that time. Take this now. You are having vomiting. Okay, take this now. Take the regular dose. You have to take this for 3 days, or you have to take 3 times a day. And also SOS doses. Okay, SOS doses in between, when the patient is regularly taking, I've already told, breakthrough vomiting, right? What is it? When the patient is taking tablets also, in between they might have some 1 or 2 episodes. That time they can take SOS dose. Okay. In morphine also, I think you have learned about SOS dose, no? Breakthrough pain. There you have breakthrough pain. Patient is already on medication, pain subsided, but sometimes the pain will come, and then you will take a SOS dose, right? Like that here also, if the patient is having vomiting, you have given tablet, regularized it. In between, you have 1 or 2 episode also, you can give one SOS dose. Choose parenteral route if continuous nausea vomiting. We already told. If single antiemetic, this is what I told, combination. Single antiemetic may not be adequate. Sometimes, okay, if the patient is raised ICP, the patient is having raised ICP and uremia. So first you will try with dexamethasone. Okay, we already told raised ICP, you give steroid like dexamethasone, hydrocortisone. All these things are examples for steroids. So you can give dexamethasone. Because of the uremia, you already told, when there is a liver failure or renal failure, and the patient, there will be direct stimulation of the CT cell, and which is the drug which directly acts on the CT cell, haloperidol. So you can give a combination. Okay, but don't like jump into combinations. First, you have to try. If it is not working, you have tried, you have regular everything. Then only you have to go for combinations. So once again, a revision, last revision. Okay. So when it is a drug induced, because of morphine, drug induced, what is the drug? Haloperidol. Okay. 1.5 milligram. No need to buy heart all these this thing. Just study about the doses. Okay. Just see it. Radiotherapy or chemotherapy. Then ondansetron 8 milligram. Stat or 4 milligram TDS. Chemotherapy. What is the drug of choice? Ondansetron. Again, for metabolic, like liver failure, renal failure, what you can give? Uremia, what do you give? Haloperidol. For raised ICP, what do you give? You give dexamethasone. For delayed gastric emptying, because of morphine or something like that, what do you give? Metoclopramide. When there is a gastric irritation, the simple gastritis, what do you give? We can give a proton pump inhibitor. It is not PI, it is PPI. Sorry, PI, and stop irritants. Was already told, opioid induced vomiting caused by different mechanisms. Drug of choice is metoclopramide. Prophylactically we give metoclopramide. Prevent with initial antiemetics. That is the takeaway point here. Do not forget. Okay, whenever you prescribe opioids, do not forget to give this antiemetic, because it will be there. If you don't give this, what will happen? A patient will take opioid, they'll start having nausea and vomiting, they'll stop the opioid, they'll stop the analgesic, they'll have pain. So, in order to prevent that, you have to give this. For anxiety induced, you have to give benzodiazepine, lorazepam, clonazepam. What we use in our hospital company is clonazepam. Okay. Now, after giving medications, is your role over? Everything I have given medication, and that is enough for the patient. No, you have to review the patient. Sometimes every person is different, right? Some drugs will work, sometimes that may not be required. So after giving medications, always you have to review the patient after 24 hours. Okay. What we do here in our hospital is our sisters, the patient comes to OP and we prescribe medications. And after 1 or 2 days, so nearly after next day, we'll call the patient and we'll ask, how are you? Hmm? And sometimes dose adjustments may be required. Okay. If required, adjust the dose. See, 1/3 of the patients may require. Okay. And revert back to oral from parenteral if symptoms subside. For example, if the patient already came with you with severe vomiting and you have prescribed IV, now he's okay. Okay. Now he is okay. Everything reduced. Now we can change to oral. Why you want to continue IV? Okay. So all these things has to be done. So this is the end of the class, and this is the last slide. Hope you have understood, and if you have doubts, you can ask. This is a little bit difficult topic and easy also. I would call it as easy. Initially, it was difficult for me. Okay, so if you have doubts, just ask me. That's the end of the class.
Dear participants, kindly ask your doubts. Our faculty is with us. Anish ma'am, we are on mute.
So, if you have any doubts, you can put it in chat box. Otherwise, saying thank you, ma'am.
No, no doubts. I think my class was so so understood, I think.
Thank you so much, ma'am. It's a very good session actually. Thank you.
Thank you so much for your patience. See, you will forget this, okay? Just by listening to one class, it will not register, will not be registered. You have to read about this. Okay, read. If you
The
have doubts,
students.
you can message. Okay, you have some. This is little bit tricky. So many new things are there. I'm this anticipatory vomiting and all. This is not very common. So if
Yeah.
someone comes and tell you this, you will think that they're talking about some blunder. So you have to you first of all you have to know about this. Okay.
Thank you, ma'am.
Thank you, ma'am. Dear participants, we can wrap it up for today. And thank you, all participants. You can leave now.
Thank you. Thank you all.
Thank you, ma'am.
Thank you so much.